Hi everybody, Ziv Simon here. I'm the creator of SurgicalMaster, the surgical training for dentists. Welcome to another video, and in this one I'm going to talk about treatment of a pathological lesion that appeared in the aesthetic zone. I'm going to show you how I managed it and what was the lesion itself. And this is basically a follow-up on a post on Facebook and other social media where I showed this case in pictures, but there were a lot of details missing, and I wanted to create this video to explain a few things. The reason this case was interesting to me and a lot of other doctors was that, if you have a lesion in the posterior where nobody can see, you basically biopsy it and you find out what it is and you know what to do. But if one of those lesions appear in the aesthetic zone of a young, pretty woman, you think twice before you remove any tissue. So that was a great case, and I'll show you exactly what I did. But before we get started, very commonly, for this case and other cases, a lot of the doctors are asking me, Ziv, how difficult is what you're doing? How difficult is it? And basically what they're asking is, can I do that? Is that a difficult thing? Is it challenging? Do I need some special training for that? And that's a really great question. And I gave this a lot of thought because it really depends on your level of expertise and your risk tolerance, and in combination with a procedure that may be tricky and involved and complex. All of these things will affect the difficulty of this procedure. And when I thought about it a little bit further, it's very similar to skiing. When you go down the slopes in a ski resort on a mountain, there are different types of slopes. There are different levels of difficulty. You have to be sometimes an expert. You have to be a great skier, or you can get by with very little skills and as a beginner. But then you have to choose a slope that is appropriate to your level. So skiing really makes a good distinction in regards to different levels of difficulty and maybe even risk. So when we talk about surgical difficulty, it's really not the difficulty, because everything can be difficult and life is difficult. It's more about the complexity and the steps that you need to take and being prepared. So I wanted to take the ski example and assign a level of complexity to each procedure that I teach. And that will give you an idea about the level of preparation that you need to take before surgery, the level of risk, and how complex this procedure is going to be in your hands. So it's really not about the difficulty, it's more about being prepared and knowing the different steps and the different options and how complex the procedure really is. And we're going from green, that is a relatively uncomplicated procedure that usually goes very straightforward, and increasing the level of complexity to a blue, where you may need to take a few extra steps and it may be a little bit more technique sensitive, into a black diamond where there may be some more surgical liability, like working in the aesthetic zone, and more complex situations in the double diamond where you're dealing with very severe tissue deficiency, where failure is going to have very significant ramifications, all the way to orange, where we're dealing with a procedure that is pushing the envelope, where you're doing heroics, and that happens also sometimes. We need to help our patients in need. So here you have all the levels of surgical complexity, starting from very low complexity all the way to high complexity procedures. So when I thought about it, I also wanted to give these complexity levels a quantitative value, not just a description. And I thought maybe I should call it beginner, advanced, maybe an expert and a super expert. But I didn't like it because it's, number one, it's judgmental and it's being opinionated. And also, it's all relative. Our skill set is so different from one another, so I didn't think it was fair to compare that. And I also wanted to stay away from terms that describe difficulty and focus more on complexity. So in future teaching and training, I will assign a level of surgical complexity so you can be prepared and have an understanding. And it is totally subjective. It's totally my opinion. Even procedures that are highly complex have parts in them that are actually very simple to do and are not complicated at all. So I'm going to factor everything in and assign only one complexity level for each procedure. In this video, I'm going to show you how I treated the lesion in the aesthetic zone and the different steps. And the surgical complexity of this case was a black diamond because it involved a few steps. Some were very simple, some were a little bit more technique sensitive. And when I factored everything in, this is the level of complexity that I assigned for this case. Okay, so this patient is a female patient in her 30s that presented to my office with a red lesion on an upper cuspid on the left-hand side. It all of a sudden appeared a few weeks ago, and her dentist was a little bit concerned, tried to scale and root plane this tooth without success, and the lesion persisted. And it was also an aesthetic concern for her because it did show in her smile. And this is the point where this patient was referred to me. And the question is, what is it? What is the diagnosis for a lesion like that? The patient is not pregnant, and she's all in all healthy, is not taking any medications. And we really need to get to the bottom of this. We need to find out the diagnosis. Now, you don't have to put a lot of pressure on yourself to come up with a diagnosis, because naturally what we need to do is perform a biopsy, and we need to submit it for pathologic evaluation and looking at it under a microscope, and that will bring us to a definitive diagnosis. But you can perhaps assign a group to this lesion, and when we think about oral pathology, it can get confusing because there's so many things that can appear in the mouth. So don't fall into the trap of assigning a diagnosis before you perform the biopsy, but you can certainly let the patient know that this lesion may be one of the following groups. It could be possibly a reactive lesion to some type of irritant under the gum or foreign body. It could be inflammatory or infective. It can also be neoplastic or a tumor. And sometimes we have autoimmune conditions in the mouth that present in a similar way. So really, this lesion could be everything. And what you need to convey to your patient is that this lesion needs to be biopsied and submitted for an evaluation. So the treatment plan for this patient is to perform a biopsy. I recommend an excisional biopsy, which removes the whole lesion with a very small part of the healthy borders, but not a whole lot because of the presence of the lesion in the aesthetic zone. And then submitting it for pathologic evaluation. Once we did that, we now created the second problem. We created recession by definition, and we created some type of compromise to the aesthetics. And we need to take this really seriously and consider doing a tissue graft to correct the recession. Now, the timing of it can vary. We can do it at the time of biopsy, which is the approach I took, or we can wait for everything to heal and perform the graft later on. I felt there was an advantage to do it at the same time because it was a surgical opportunity. The patient was already anesthetized. The area was already deficient and receptive for a new graft. And there was really no downside because if we needed to go back and graft in the future, we always have this option. So the treatment plan is to perform the biopsy and graft tissue. So the first part of the procedure was relatively simple. I performed an excisional biopsy. I carefully used the number 15 blade and used it around the lesion, resected it, put it in a container with formalin, and sent it to the pathologist. And what we can see now is the recession showing. The tissue is obviously very inflamed. It's hyperemic. It's very friable, very poor tissue quality because of this lesion. And in this situation, we have a few options. I chose to use an autogenous connective tissue graft from the patient's palate because I felt this would be the most predictable and safe in a tunneling approach. And that means that I'm going to use specialized tunneling instruments, and there are different kits on the market. And these instruments allow me to create a space under the existing gingiva and the adjacent teeth to insert my graft. And basically the approach is through the sulcus. So I'm going to use a number 15 blade to start with, and then very carefully use my tunneling instruments underneath the gingiva without reflecting the papilla. Now, the area of tunneling is going to be beyond the mucogingival junction. We're basically creating a pouch or a space underneath into which we'll insert the graft. And once this graft is secure, it will get blood supply from the overlying flap, from the underlying periosteum and bone. And there's a good chance it will heal and correct the deficiency. So when you're using tunneling instruments, you have to use them very carefully. They often have certain curves that are by design to allow you to reflect the tissue, work very close to bone. Often we work in full thickness because we are trying to prevent perforations. And when you tunnel, it's very important to take your time, take advantage of the different shapes of the instruments, and very carefully work your way in an apical direction, sometimes in semicircular movements. Very carefully, be careful not to detach the interproximal tissue, the papillae, and slowly work your way apical beyond the mucogingival junction so you can have the space to insert the graft, to have good vascularity, and to some extent, it'll allow you to reposition some of this tissue coronally when the time comes. Now, in a tunneling approach, we are working in a full thickness. The reason being, we would like to maximize the tissue thickness because one of the risks of tunneling procedures is a perforation, which can obviously cause failures and problems. So we're working in full thickness. And when you completed your tunneling preparation, you'd like to see patency between the sulcus of the tooth you're treating to the sulcus of the adjacent teeth. And I call it prove your tunneling. I'd like to see that. I'd like to see that the pouch extends beyond the mucogingival junction, and then you're ready for your tissue harvest. Now for this patient, I harvested a connective tissue graft from the hard palate, from the left side, which is the same tooth we're treating. You always would like to contain your surgical site. And I used the one incision technique, which is actually made out of 6 different incisions. In future training, I'm going to show you exactly how this harvest works and what are the great advantages that you can have by using this technique. So connective tissue was harvested from the left-hand side of the palate, and it was of relatively good thickness and good length. And what I did then, I connected 2 sutures to the graft. Both were resorbable sutures that allowed me to guide my graft into the pouch preparation. Now, if you don't use this, what I call the two-tail graft, You can simply use your tunneling instrument and very carefully direct the graft into your tunneling preparation. So the graft is secure. You can see the sutures that are securing it, one on each side. The graft is peeking through in this area, but really the majority of the graft is right underneath the tissue in the tunnel preparation. Some of it is beyond the mucogingival junction, and that ensures that this graft will get good vascularity. Now, if you can, I recommend you place sling sutures to pull the existing flap on top of the graft. Now, I was not 100% successful with that because the tissue was very thin, very friable, and I was concerned with perforation. So I didn't want to apply too much coronal pressure, and I counted on the fact that the majority of the graft is well secured and under vascularized tissue. So you need to gauge and see how much pressure you can put, because you wouldn't want to go through this and then just by applying coronal pressure with the suture, the tissue can rip and get damaged and you'll compromise the result. So at this point, the patient is ready to go home. I prescribed systemic antibiotics and pain medications and gave some oral hygiene instruction in the area, but no periodontal dressing or covering. Basically, this area needs to be left alone. So the patient came back a week later. She had some moderate pain from her palate that was controlled with medication. But if I look at the recipient site, we see all in all that the tissue looks red, looks vascularized, but there's a white area right in here. This is part of the graft that is laying against enamel, and this part is not vascularized at all. So there's no reason to be concerned. As long as you see some redness peeking through, don't get discouraged. Show the patient how to keep it clean with a very soft brush, staying away from the gingiva. And another week later, you see a very significant hyperemia. It almost looks like the original lesion, but it's not. It's basically the connective tissue graft healing, which is very typical and is very good. The color red is the best color for grafting. It demonstrates vitality, vascularity, and that the procedure went well. If you're seeing the color white or gray, it's really not a good thing, because that indicates necrosis, which is obviously not the case. So every week, you should expect some improvement in the tissue. This is the 4-week follow-up. We're starting to see an improvement in inflammation. You'd like to work on the patient's oral hygiene by carefully showing them how to floss and carefully brush. And if you wait enough time, this inflammation will be almost completely resolved with no recurrence of the lesion and a very good aesthetic outcome. Now, when the results came back from the pathologist, it was actually not what I thought it would be. I thought it would be a pyogenic granuloma, but it was actually something called a peripheral fibroma, which is a borderline benign tumor that originates from the PDL. It has a recurrence rate of 10%. So I'm following up this patient very carefully for a few years now, and there was no recurrence. And that really demonstrated to me, and it taught me how important it is not to jump into conclusions and not to make any assumptions before you take a biopsy and get the pathological report back. So in this case, I showed you how I managed a lesion in the aesthetic zone, first by taking a biopsy and also grafting at the same time with a connective tissue and a tunneling approach. And that's one way to treat this type of problem. I hope you found it very helpful, and I hope you know what to do when these types of situations present in your office. I'm also happy to work with you on your surgical skills, show you more things and different levels of complexity, so we can learn together and get better, and you can become more knowledgeable and experienced, so you too can help your patients and perform these procedures and be a good surgeon. Now, if you like this video, Feel free to share it with your colleagues, with other dentists that may be interested in the same topic. Leave your comments below this video. Give me some feedback so I can create more interesting presentations and more training programs for you. And you can also go to my website, SurgicalMaster.com, and opt in for my weekly videos and blogs so we can learn together and get better, help our patients, build our practice, and in this process, also have a lot of fun. There's a lot more coming, so I really look forward to seeing you and working with you in the future.